next speaker is Taylor Dishon. She will discuss speech and language pathology updates in stroke rehab. Taylor is an ASHA certified medical speech language pathologist who graduated with a Master's of Science in Speech Language Pathology in 2017. Over the last 5 years, she has had the opportunity to provide evaluation and rehabilitative services for a variety of medically complex individuals with a particular interest in neurological disorders across the continuum of care.
Hello, everyone. Good afternoon. Thank you again for having me today. So today I am going to talk about the SLP role in acute management of stroke, an inpatient, and as well as updates and rehabilitative options. So jumping straight into it, I have no disclosures. So the SLP scope of practice is extremely wide. We play a role from the initial screening process to initial treatment, to management with multiple disciplines, to initiating a rehabilitation plan. So today I'm going to break it down into two simple branches: dysphagia, multi-phase dysphagia, and communication disorders of many types. At the acute level of care, the goal is to assess a patient's swallow function at the bedside within 24 hours of receiving a consult, and for communication, to assess the patient's communication needs or identify the need within 48 hours of receiving a consult. So to kick off the dysphagia component, I thought it was relevant to highlight a heavily referenced oldie but goodie article in the speech pathology world by Langmore and colleagues. They looked at what are the predictors of aspiration pneumonia. So what sets a person up for higher risk for developing pulmonary complications or even malnutrition secondary to a dysphagia, besides the obvious having the presence of an oropharyngeal dysphagia. So 3 other domains that have been consistently shown to contribute to this would be the patient's overall medical status, their overall functional status, and their overall status of their oral health. So taking a deeper dive into the post-stroke population, research indicates that patients over the age of 65 may be at higher risk for developing pulmonary complications secondary to dysphagia, severity of their post-stroke deficits, so highly related to NIH scores. Is this patient now non-ambulatory? Is this patient now cognitively or linguistically compromised? Is this patient unable to self-feed? Is this patient now dependent for oral care? All of these factors play a huge role into if this should be a concern or not. And then lastly, how and if they are able to complete the 3-ounce water swallow test, which I'll get into on the next slide. So our initial encounter with patients in the acute care setting is at the bedside. The clinical swallow evaluation is highly subjective, so why does it matter? So that's the first interaction we have with this patient. This is when we get to evaluate what their post-stroke deficits are, how they're communicating. Do they have severe dysarthria? Are they managing their secretions? Is their cough response appropriate? We're able to not only evaluate the obvious, but we're also able to play investigator, collect all of these risk factors and determine which type of category this patient falls into. Is this patient post-stroke at high risk for dysphagia? Can they not have an oral diet until we have performed instrumental swallow evaluation? Is this patient maybe experiencing oral dysphagia where we can manage this at the bedside with low suspicion that they're having issues maintaining proper airway protection? We also get to really have the opportunity to develop rapport with the patient, families, and caregivers, which definitely plays a role into the rehabilitation process. I wanted to touch base on updates for the Yell Swallow protocol. So this is, a very well-validated tool, not only in the speech pathology world, but nursing staff completes this at bedside as well. Specifically, updates in this area, Suter and colleagues wanted to look at SLP reliability, performing the 3-ounce water test at the bedside, and how that patient subsequently performed under fluoroscopy. And time again, it proves to be a highly sensitive tool across the bedside and across, instrumental swallow evaluations, 100% sensitivity, and all patients who were able to successfully complete the 3-ounce water test did not aspirate under fluoroscopy. And I want to emphasize gold standards of swallow assessment. So what happens at the bedside when we have concerns? We have to take a step further. So it's not enough to comment at the bedside that the patient coughs with thin liquids. Why do they cough with thin liquids? What post-stroke deficits are contributing to this now pathology? So not only do we have the modified barium swallow study, we also have FEES, which is the flexible endoscopic evaluation of swallow. I have a side-by-side image still frame of on the left, we have a still frame of the modified. On the right, we have a still frame from the FEES. They give me the exact same information of what pharyngeal swallow integrity looks like. I will note that at times there is a stronger preference for a modified. In the stroke population, it's very rare that a pharyngeal dysphagia is present without the presence of an oral phase issue as well. Unilateral weakness, again, it all comes down to a very thorough oral mech exam. So sometimes in the speech world, there is a little bit more of a preference to pick this as the instrumental tool over the FEES. And another consideration in this population too is if the patient does have significant cognitive or language deficits, how realistic is it for me to try to place a scope down someone's nose when they're still trying to comprehend everything that's going on, all these post-stroke changes. But regardless, these are the standard tools to tell me the information I need to develop an appropriate therapy plan. So dysphagia rehab in a nutshell. I'm going to emphasize two emerging topics that have newly surfaced research specific to the stroke population. First off, we have the McNeil Dysphagia Therapy Program, or known as MDTP. This program really focuses on the use it or lose it capacity. So if you're not using your swallow, what are you doing? Are you losing that function? What can we do in the meantime to rehabilitate your swallow? This particular program has been really heavily researched in other patient populations, such as late effects of radiation in the head and neck cancer population, chronic dysphagia from severe brainstem strokes, patients who really never responded well to traditional therapies post-stroke, years, months, however long later. But this study actually wanted to look, this was a randomized control trial, they wanted to look specifically at post-stroke survivors and how this bolus-driven therapy program stood a chance against more traditional types of therapy. So with MDTP, a patient must undergo an instrumental swallow evaluation, whether it's FEES, whether it's modified. The least restrictive texture of liquid or food is then identified. And in therapy, an 11-point hierarchy is built. And every session, the patient is having multiple opportunities to swallow, not just practice swallowing. They're actually swallowing textures of food and liquid with the goal of improving lingual control and the goal of improving a pharyngeal efficiency. So how did this stand up? So the 53 stroke survivors were divided into 3 intervention groups. One was traditional care, just traditional pharyngeal strengthening exercises based on deficits identified via modified or FEES. The other was given a vital stim treatment or neuromuscular stimulation, electrical stimulation. And then the last group was MDTP paired with sham vital stim. So in this particular study, the superior outcomes were noted with the MDT sham intervention group alone, so much so that 3 months post-treatment after follow-up, 91% of the patients were able to return to their pre-stroke diet, which is pretty miraculous. So this therapy program is not for everybody, but I do think it definitely highlights the need to consider using liquids and solids in therapy, even though it might be deemed unsafe. Research says that it might actually help. And the next study I will talk about delves into expiratory muscle strength training, or EMST. So this is an indirect treatment, as we're not directly targeting swallow function. We're targeting cough response, so the patients have a better chance of clearing their airway in the event of an aspiration event. I'm going to skip ahead real quick so you can see. So this is the device. There's multiple devices on the market. This is the EMST 150. In the middle, we have the pressure threshold device. And then on both sides, we have an oral mouthpiece, and then we have a nasal clip. So this is what we utilize in therapy. And basically, we have the patients create a tight seal on the mouthpiece. We have them try to blow air as hard as they can to try to create an audible to break the unaudible seal. So we have it labeled from 60 down to 120, and we continue to increase resistance in order to target improved volitional and reflexive cough response. So a meta-analysis, they reviewed quite a few neurologically compromised populations, but they actually included 167 post-stroke patients. And their functional outcomes specifically to the stroke patients were not only increased reflexive cough, but increased maximum expiratory pressure. Thus, patients performed better on modified barium swallow studies. They were able to protect their airway more effectively. So both two approaches that are, one's direct, one is indirect, they're both emerging, but it's really exciting to see evidence specific to the stroke population so we can really validate if this is a tool that's going to work for our folks. Just really briefly going over iddsi or iddsi. So this is new as of, I believe, 2021. I believe it was June. So this standard of diet modification has replaced the national dysphagia diets, which most of our patients admit with acute stroke. 9 times out of 10, they have some type of solid or liquid modification. So in a sense, this is a global initiative. Multiple hospital systems, outpatient settings, skilled nursing facilities are shifting towards this framework because it's easy to understand, and most importantly, it's very easy to train patient family members. So previously with the national dysphagia diet, what is dysphagia advanced? What does that mean? I don't know. So this diet framework definitely helps to give them user-friendly terminology, and instead of giving patients and family members a list of foods they can or cannot eat, it's not exclusionary. It just discusses how to test if something is appropriate for their loved ones that's prescribed by the speech pathologist. All right, moving into aphasia assessment. So there's definitely been a shift on describing and emphasizing what a patient's functional language deficits are and what their relative strengths are. That's the bone, the meat and potatoes of developing a therapy plan versus spending time and effort trying to classify a patient has Broca's or Wernicke's or et cetera. So especially the acute care, phase, because these folks, they look different from day to day, which is great, but I might see a patient who's globally aphasic on Monday, I come back Tuesday afternoon, I'm revamping a whole new evaluation because that patient is continuously, spontaneously improving. So really describing what the language impairments are and what they can do well to compensate. So we use a variety of quantitative assessment. Here at Methodist, we tend to lean towards the bedside Western Aphasia Battery, which is a formal screening tool that's derived from the comprehensive battery that's usually given in the outpatient or inpatient rehab setting. But for folks who do have very severe impairments, it's not worthwhile going through an entire formal assessment just for the sake of having quantitative information. We might assess them more informally. The biggest point that I like to emphasize in aphasia assessment is differential diagnosis. It's not enough to have a patient who is having visible difficulty with verbal expression to say that patient has expressive aphasia. Well, is it really a language-based deficit, or does this patient potentially have overlying motor speech deficits, motor planning, such as a verbal apraxia of speech? Does this patient have oral motor weakness, dysarthria? So really deciphering clinically what this patient is presenting with, because that definitely tailors the trajectory of where rehab is going to go. Treatment of verbal apraxia of speech and dysarthria is markedly different than treatment of expressive aphasia. And a lot of times it can be a combination, but that's really what we're trying to decipher at the bedside. So in terms of rehab for aphasia, there's two trains of thoughts. There's impairment-based treatment, where you're specifically focusing on an underlying verbal deficit. How can I treat this patient's word-finding difficulties? How can I treat this patient's verbal fluency, prosody? Versus communication treatment, where you're trying to give a patient any means physically they can to use for communication, whether it's spoken language, written language, gesture. It's really whole picture. And a lot of times therapy is blended. So I listed quite a few evidence-based approaches underneath. I won't go through all of them, but I'm more than happy to discuss or provide references at a later time for any of these options. I just wanted to go over two specific to the acute setting. So in the initial phase of aphasia rehabilitation, I want to give my patients and my family members as much as I can, because being in the hospital, not being able to communicate your needs is devastating and it's frustrating. So picking therapeutic options that are evidence-based, such as semantic feature analysis. This is an impairment-based treatment protocol that targets improving a patient's ability to increase semantic mapping so they can retrieve words functionally. Research has shown that there is generalization from untrained stimuli to functional stimuli in social communication opportunities. Same thing with response elaboration treatment, goal of increasing the amount of content spoken. All right, for dysarthria, there's not too many updates. Again, I just wanted to hammer on the nail head that assessment of motor speech deficits such as dysarthria differs from what you will see in verbal apraxia speech and expressive aphasia. So in our assessments, we're trying to describe the physical and perceptual characteristics of the 5 subsystems of speech, determine if they have an impact on overall functional speech intelligibility, the patient's ability to communicate with ease and socialize. All right. Okay. Last but certainly not least is cognition. So cognitive evaluation over the 5 overarching domains of executive function, memory, social communication, problem solving, and attention. So similar to aphasia assessment, we strive to provide quantitative information, whether that's through a screening tool like the MoCA. Here at Methodist, the speech pathology department tends to prefer the basic version of the MoCA. We just feel it has a little bit more of a functional edge. But importantly, if a patient has a perfect score on a screener such as a MoCA, but they've had a right CVA, they were previously independent working, and you informally are noticing X, Y, and Z, it is imperative that you take a step in the right direction and try to give them a higher level assessment. Here at the hospital, we typically like to give the cognitive linguistic quick test, which is a comprehensive battery. It does take more time to administer, but it is criterion referenced, and we are able to obtain a composite score with a correlated severity score based on that patient's age range. For treatment considerations, treatment is a combination of restorative focus and compensatory strategy training. We're going to always prioritize deficits that have prominent impact on the cognitive domains. So if a patient is unable to attend to basic stimuli, for my treatment approach, I'm not going to try to cover all 5 domains if the one deficit that they are presenting most prominently with is impacting. So really prioritizing how to make your treatment most effective. And then, lastly, understanding what a patient's prior level of function was. So if a patient was independent prior to coming in with acute stroke, working, driving, their evaluation and their therapy might look a little bit different and a little bit geared to higher level skills versus maybe an elderly man who came in who's now retired and is still independent, but maybe isn't managing his medications independently, maybe isn't managing finances. That's going to look a little bit different. I'm not going to target things that patient is normally not responsible for. Lastly, cognitive rehab, specifically in the acute setting. Cognition, as we all know, is it's an abstract topic, it's an abstract concept. So how do we address this with evidence-based practice? So a lot of the foundations for cognitive rehab draws from other disciplines as well. So educational psychology. So in this case today, I'm going to talk about metacognitive strategy training. So what can we train the patient to do in any given task? So thinking of metacognitive skills, there's 2 dimensions of thought. There's metacognitive knowledge. So is the patient aware of their cognitive abilities? Are they aware of the strategies available? And are they aware when and how to use the strategies? The second dimension would be metacognitive regulation. So the patient knows they know there's a deficit, they know there's a breakdown, they've selected a strategy. How does that strategy help them through a task? How does that help them complete any basic living task that they want to get through? So it's kind of a vicious cycle of planning, monitoring, evaluation, and reflection. So I like to approach rehab of cognitive skills from a framework. This framework can fit attention deficits, memory deficits, problem solving. It really can blend into a functional need for the patient, on top of some of the other strategies that we'll work on, internal and external memory, compensatory strategies, and et cetera. All right, and these are my references. Thank you.